Hello and welcome back to the Home of Medicine podcast with me, Dr. Amie Burbridge. Today I am joined by...
Hi, Dr. Ben Lovell here. I'm an acute medicine consultant working in London in the UK and a big fan of the podcast.
Fantastic. Ben, we're a big fan of yours. It's always brilliant to have you on board. So I'm going to talk to you about a case today. I want some, I guess, a little bit of advice from you, some reflections from you on how I dealt with it. And obviously, as always, we're going to talk about the clinical reasoning behind the case and tease out some learning points for our listeners. So as ever, I like to set the scene, and it's a busy Saturday. It's always a Saturday. And interestingly, this is the same Saturday as the case I talked about with Stephen Laird a few episodes previous, called diarrhea. So it was a busy, chaotic Saturday. And it was actually towards the end of my shift. And as sometimes happens, patients who should have been seen sometimes get missed. And they may have moved a few times around the ward, the notes may have gone missing, or for whatever reason, this lady was not seen when she probably should have been seen. So when I came to see her at 9 o'clock at night, she was very unwell. She'd presented around 2 o'clock in the afternoon, and she presented with shortness of breath and a cough. And she was 52 years old. It was flu season, COVID season. It still is. So there was a lot of assumption that a lot of people then were coming in and it was flu, it was COVID. You know, it was one of those things. And at the time of admission, she'd had her observations done by the admitting nurse. And she was found to be tachycardic, hypotensive, pyrexial, and looks really sick. For some reason, whatever, this patient wasn't highlighting myself and she didn't get seen. So when I saw her at 9 o'clock at night, I walked into her bay and she looked awful. You know, when you walk in and somebody just looks ill. So she was sitting on the edge of the bed, holding onto the edge of the bed, really clutching, because she felt that if she sort of sat up straight and stretched her arms out, she could take deeper breaths. And it was obvious that she was very, very short of breath and very, very difficult to take deep breaths. So it was very, very shallow breathing. She was sweaty. She was pale. She was tachypneic. And her respiratory rate by the time I went in was around 30. So it was extremely high. So my end of the bed assessment was, this patient's ill. I need some help. I'm going to go and get somebody who can come and do a up-to-date set of observations while I have a quick chat with her and start to think about some blood investigations. She hadn't had any tests done, so there was no x-ray done, there was no bloods done, nothing could be done on this patient. So I went back to basics and did an A to E assessment, and her airway was patent. She was chatting, and she was able to tell me that she'd been well until 2 days previously, when she started to feel short of breath, developed a productive cough of green sputum, and she also felt very feverish and had lost her appetite. And she was very, very tired and fatigued. I didn't really want to ask her too many questions because she was so short of breath. So unusual for me, I said, just give me a yes, no answer. So I didn't want her telling me the whole story. So I said, have you had a headache? No. Any diarrhea? No. Waterworks, are they okay? Yes. So it was very I wanted to get some information, key information out as quickly as I possibly could. She was breathing, but her respiratory rate was very high, and it was 30 to 32 per minute. Her oxygen saturations, when I checked them, were 82% on room air. She had no oxygen. So the first thing that I did was I got 15 litres of oxygen via an on-rebreathe mask to try and help with those oxygen levels. Her blood pressure was actually okay. It was 110 over 80 when I saw her. Her heart rate was 120. She was tachycardic. She was pyrexial at 38.7. Moving on to her glucose. So we did a venous blood gas. The glucose was normal. It was within range. It was 6.2, which was fantastic. Her lactate was 6. Her pH was 7.32. So she was a little bit acidotic. We did a VBG, so we were unable to comment on the oxygen saturations, but her bicarbonate and base excess were at that time within normal limits. So I examined her chest, and on both sides of the chest, she had reduced air entry. There was no wheeze, but there were significant crackles at the right base. And the left base was actually okay. And you could see a bit of tracheal tug. So she was really, really struggling to breathe. Her heart sounds were completely normal, couldn't hear anything. And she had no pedal edema of note. Her calves were soft and non-tender. She had no lymph nodes of note. She just looked really sick. She looked septic. She looked ill. And when I listened to the lungs, I never listen over clothes because it's like a bugbear of mine when you listen over the whatever they're wearing. But what I did is I put my stethoscope down the back of her gown that she had on. So I didn't actually look at the area, but I just listened down the back. And that was when I found out these crackles. And that is an important point that I want to make and to highlight at this moment is how I actually auscultated the lungs. So what are your thoughts at the moment?
This lady, well, I don't know what else is going on, but this lady, for me, wins the prize of sickest person in the department. I'm thinking from what you described, my working diagnosis is community-acquired pneumonia with sepsis. The lactate of 6 horrifies me. Her hypoxia terrifies me. I mean, I love these type of patients. That's why I did acute medicine. I love looking after these patients who are sick, but the way you're describing the business department, 9 p.m., that's handover time. It's a very vulnerable spot staffing wise to be really digging down with a sick patient. And these are the non-clinical, sort of the human factors of the workforce we live in. And she sat there for a while. She's going to need a lot of medical care, but she's going to need a lot of TLC, I think, and reassurance, because she must be terrified out of her wits. She's 52. So if this was me alone, I would certainly be asking for help. There are some things I'm brilliant at in clinical life and some things I do need a bit of help with. And in terms of getting tests done, getting IV access, getting things prescribed, I think that's quite a lot for one person to be doing. I'd be thinking about confirming or refuting my hypothesis that she has community-acquired pneumonia. So I would like to do the sepsis 6. I've been drilled very nicely with that, thank you. So blood cultures, broad spec antibiotics, fluid boluses, accurate urine measurements. I want to get a chest x-ray to look for consolidation, and she needs all of her bloods doing. I don't think I would delay the administration of antibiotics whilst waiting for chest x-ray and bloods. I've got enough evidence now to give her something broad spectrum as part of the resuscitation, the care bundle of the sepsis 6. So in my hospital, that would be IV cefuroxime is our treatment of choice, although I've worked in places where IV comoxiclav would be the first line. And then I'd be thinking about trying to normalize some of these observations. Can I bring the heart rate down? How much fluid does she need? Can I bring her fever down? How antibiotics? What's her fluid status? And is there anyone else who should know about this patient? I appreciate we haven't done therapies yet, but at what point am I going to be making a phone call to the HD or the ITU outreach to say, I've got a profoundly septic patient here? I know that we have to give fluid therapy first before we diagnose septic shock. It has to be refractory to fluid therapy. But sometimes you get a handle on who this is going to be before you start it. So I'd just be thinking about how am I going to maintain safety? This patient's already fallen through the cracks of our healthcare system. She cannot fall through another one. We can't give her some treatment now, and then by the time the poor night team get around to seeing her, it's 2 a.m. and she's deteriorated further. So she needs a robust plan over the next 60 minutes and then thereafter to check responsiveness to my treatment and then signaling any deterioration. Whew, that's my blurb.
Yeah, absolutely. And you had exactly the same thoughts of me. You know, I'm an acute physician. I actually like looking after sick patients, but she was really sick. I agree. I think we missed an opportunity here to have picked this up earlier. However, we did treat, as you said, we did the A2E assessment, we gave her fluids, antibiotics, we did the sepsis pathway, and I did speak to the intensive care outreach team very early on, because maybe it was my gut instinct, she looked sick, and I knew she was sick. And I didn't have time to, or I didn't actually ask her about her past medical history because she was so unwell. So I then went back to the computer system and looked at her past medical history. And a few years previously, she'd had aspergilloma, which had resulted in some of her a lobectomy. And because when I examined her, I examined down the back of the clothing rather than actually undressing her, I didn't see the scar. And that was one of the first things that I think I could have missed on. Probably wouldn't have changed the management plan, however, at that time. So I would have managed her acutely exactly the same. So I spoke to the intensive care unit. They were going to come down and see her, and they were happy with the plan that we got. And she was a little bit more stable. I contacted the family, and very reluctant partner was to come into hospital. It was a Saturday night. It was late. I understood that. Sometimes it can be hard, and I did explain, how unwell I felt that she was, and that she may be going to the intensive care unit, but still wasn't very keen to come into hospital. So, okay, that's fine. So I then looked at the x-ray that we had done. We had a portable chest x-ray done, and the portable chest x-ray showed quite significant consolidation at the right base. And this would fit with a community-acquired pneumonia. So we treated as community-acquired pneumonia and sepsis. And I was happy with the management plan that we put together. I was happy that the intensive care units were involved, and they were going to come and see her after handover. You are exactly right. Handover is at that critical point, and that can be challenging. So we thought about, will she need a catheter? We're going to give her lots of fluid. There's always a risk of, when you catheterize somebody, of, are you going to introduce more infection, particularly if somebody's mobile? So we weighed up the pros and cons about catheterization. We decided to catheterize in the end because she was so acutely short of breath. And given the fact that we were giving her fluids, if she was to need the toilet, it would have been very difficult for her to mobilize to the toilet or to keep lifting her on and off the toilet or the bedpan. So we decided that at that short amount of time, that was probably not a bad idea. Blood cultures went off, all the bloods went off, which, as you can imagine, CRP was grossly abnormal. It was in the 300s. She had a raised white cell count. She had a neutrophilia. She had an acute kidney injury. And she had everything that you could possibly imagine. So I was happy with the plan for this lady. And I went home a couple of hours later and went back the next morning. And I pleased to see, in a way, that she was in the intensive care unit, because I think that was where she should be, and that was where she was going to get the maximum optimal medical care that she required. And I like to follow my patients up, so I reviewed all the bloods again, and I looked at chest x-ray. Now, I never trusted chest x-ray reports. I always like to look at it myself and then look at the report, because sometimes I'll be like, the chest x-ray showed this, and I'll be like, but I want to look at it, because I think to actually be able to interpret chest x-rays, you can't look at the report, you need to view the report. So I looked at this chest x-ray on the Saturday night, and in my tired state, I've seen thousands of x-rays knowledge, I saw a pneumonia and I moved on. So really what we should do whenever we review an x-ray is to follow the A to E approach. So A is for airway. Is the airway central? B is for the lungs. So can you see anything in the breathing area that you are worried about? Well, I saw a pneumonia. I stopped looking. I'd found a diagnosis, I'd satisfied my search, and I stopped. We call that premature closure. I didn't need to look for anything else. My diagnosis was there. So I didn't look at the heart, I didn't look at the diaphragm, and I didn't look elsewhere. So E is for everything else. So that normally involves the bones. We look at, is there any fractures? Is there anything else that I can see in the lungs? And I didn't. I'd found my diagnosis and I stopped. So I looked at the report, because I always like to look at the report and go, am I right or not? And the report said, this lady has a right-sided pneumonia and she has multiple rib fractures. And I went back to the x-ray and was like, oh my God, how on earth did I miss those multiple rib fractures? And they were new. And these rib fractures were by the area on the right side. So they hadn't got any signs of healing, so they were presented as acute on the report. So she had multiple rib fractures and this pneumonia. So I started to think, okay, where have these rib fractures come from? And did the rib fractures cause her not to be able to breathe as much? And then did that lead to the development of the pneumonia? And I started to really be cross with myself, because I did what I always tell people not to do, and that is to stop looking. Okay, that is when you've got one diagnosis and it fits what you want it to fit, it fits your diagnostic scheme in your head, you stop looking for anything else. And in this case, I really, really messed up. And there were a few, I guess, sort of alarm bells. So when I saw the patient, she was extremely unwell, but she was by herself. And we were allowed visitors, so she could have had somebody with her. And when I spoke to her partner, he was very reluctant to come into hospital. And there was a rib fractures. And I was like, what am I missing here? What is going on here? And post ITU, she was discharged to one of our medical units. Or I saw her, and she'd had a really good recovery actually from the pneumonia, which was fantastic. So we got her to the intensive care unit at the right time. And what they picked up in the intensive care unit was the multiple bruising that this lady had on her body and that I'd missed. And these bruises were where she'd been injured on the lungs, but there were also bruising elsewhere on the body. And it turned out this lady was a victim of domestic abuse and domestic violence. And it was extremely distressing and extremely sad that I think a lot of us had missed it. We had I'd not examined her properly. And I hadn't taken her clothes off, I hadn't lifted her clothes up to have a proper look, and I'd missed these bruises. And I was completely blinded by the other diagnosis of the pneumonia that I hadn't even stopped to look for anything else. And it really, I guess, highlights to me the importance that patients can have more than one diagnosis. Patient can have other things going on, and the importance of the general examination and really examining a patient, having a look, not examining through clothes, not examining through the gown, but undressing a patient and really having a look and take something didn't fit right and didn't feel right, but I didn't know what it was. And it was a very, very difficult case, actually.
I've been
And
called out before by the same thing, the examining through clothes, and I've seen other people miss bruising, and one that stuck in my mind was a horrible attack of herpes zoster on someone's chest wall, which was just missed because they came in with chest pain due to the zoster. Did a cardio exam through the clothes, missed the cause. And I think what you're driving at is that you made an incomplete diagnosis. You diagnosed pneumonia, and I guess the full diagnosis would be pneumonia in the context of rib fractures, in the context of domestic violence, and that would have given you a more meaty plan at the post-take ward round. You said it yourself, those things wouldn't have changed management overnight. And obviously, because of the resources available to you, you were focused on the life-threatening findings at the front door, which was, it's better that you got those rather than you identify the other issues and missed those. And there is a reason why we don't, it's not one and done in the healthcare system. We don't, the patient doesn't meet one doctor and that's it. We cycle our assessments, we reassess, new teams assess, and people moan about, oh, what a continuity of care, and they're right. But the good side of moving through different teams is that you have more different pairs of eyes. Yeah, they met a consultant at the front door who was at 9 p.m. on her own and was working with a very sick septic patient. And I appreciate it's very frustrating to oneself when you miss something. But she then met an ITU team and she met a medical team. And by the time she left hospital, all the bits and pieces had been picked up and were addressed. And I know the onus we put on ourselves we got to identify absolutely everything at the front door in acute medicine, I'm assuming in emergency medicine as well. But sometimes we have to make a very unpleasant choice. What are we doing today with patients? Fine detail or broad brushstrokes? And sometimes we can only do broad brushstrokes. Septic pneumonia, okay, we can treat this and then leave the fine little detail of the rest of the picture to other people at the rest of the inpatient journey. Sometimes we have to make that horrible choice and leave it that way, but trust our colleagues will pick things up. So I'm not saying, oh, don't feel bad. Of course you feel bad, but the patient was not failed by you, or after she was missed for several hours, she was not failed by the system. It did what it was supposed to do, which was pick up everything and identify everything. So if you were one of my supervisees or one of my doctors coming to me, this is what I would be saying to you, saying you did the best you could with the resource you had at the time. And fortunately, everything else is picked up as we went along. What will we do differently next time? But there's no point ruminating and self-flagellating too much about not being a superhero at the front door, because if we could do that, wow, there'd be no stopping us.
you'll be invincible. Yeah, and you're absolutely right. I think at the time it doesn't feel like that, does it? It feels like I failed her because I didn't I always feel like I should take the holistic approach. I should find out about her social history. I should find out, does she have any dogs at home? What sort of work does she do? And often I do that, but you're right, in the situation, she was too sick to have that conversation anyway, so it wouldn't have been appropriate. And, we treated what we had in front of us. What I didn't do was assess the x-ray properly. I assessed it using my type 1 thinking, my fast thinking, my experiential thinking. I didn't look for anything else. I found a diagnosis and I stopped because I didn't need to look for anything else. And this often happens. You diagnose a UTI, so you start looking for that septic joint. And it's not uncommon, particularly when we're very busy and we have 35 people to see, and it's you are conscious that the pressure is on you to see patients in a timely manner. I think moving forward, and I guess the key take-home points that I want people to take away from this are, first, it's about the examination. So if I had undressed this lady and done a full systematic examination, I would have seen the bruising. Similar with your herpes zoster. Somebody presents with chest pain, take the top off. Is there any dermatomal herpes zoster that could be causing the pain? Absolutely. It's the same with infected legs. I often get diagnosis of cellulitis, but the legs are dressed. You can't diagnose it. So I think it's always really important to take those leg dressings off and have a really good look at what's going on underneath those dressings. So that's one, is examination. I think number 2 is premature closure. I prematurely close the diagnostic process at that point. And maybe I should have thought a little bit further, looked at the x-ray and picked up on those fractured ribs. And number 3 is visceral biases. You meet an individual and you make a decision about that individual within the first minute or two. I would never, ever have thought that this individual was a victim of domestic violence, domestic abuse. And that is my own biases. And I think it's definitely maybe being more aware that this is something that we need to be thinking about, particularly if we do see something like fractures or bruising, definitely on an individual. So yeah, some interesting learning points there. Everything got sorted out in the end. She had the right support and she went home with the right support in place from the domestic violence and the domestic abuse side of things, but also from the pneumonia. She made a full recovery, but still a difficult case.
One thing I just want to end on, is a really interesting point. If you people listening, Google gorillas on chest x-ray.
Oh yes.
Have you seen it?
I use that in your teaching sessions, yeah.
Brilliant. And if your clinical question for a scan asks one question, you are biasing the reporter, and these are radiologists who do it for a living, to answer your question. And it's fantastic. And it's a very fun study where they put tiny little toy gorilla, they stuck it on people's x-rays or CTs, and then asked the radiologist a question, and a whole bunch of radiologists missed a blooming great gorilla grinning at them on the screen. They didn't see it because they were answering the clinical question. Part of a wider discussion about what you write on your clinical request for radiology scans, make your question focus, because that's what we're going to look at. But, if radiologists who sit and do this for a living can miss a gorilla because they're being asked a different question, if you're asking yourself a question, is there a pneumonia? Is my hypothesis correct? And you miss some rib fractures, and chest x-ray is not the right modality for looking at rib fractures, then
that's true.
You'll be excused as well. It's the bias of the question. So you'd answered your own question.
Yeah. And, should we ask, when we're trying to ask a clinical question, then should we always try and formulate 2 questions we should ask from every investigation? I don't know.
Well, I had a great talk from a radiologist recently who said that the reason why, if you think someone's got a certain condition and you request a scan, if you don't word your request properly, that's how things get missed. And that's how sometimes if you go back to the radiologist or the MDT and say, actually, we've got a new clinical question, can you look at these images again with this question? They'll suddenly find things that were missed before because they're looking for it. So it's always worth rediscussing scans that have already been reported in light of new clinical information or if a new question arises.
I think that's a really important point. And what I try and do is, when I'm requesting a scan or some form of radiological investigation, is actually write clinical questions on my clinical queries on there, rather than shortness of breath query cause, because it could be absolutely anything. So could this be a granulomatosis with polyangiitis? Be a little bit more specific as to actually what you're looking for. Definitely.
I like that.
Yes. Any learning points for yourself then from that one?
No, I'll leave you with one tiny little nugget. Do you know if this patient ended up having pneumococcus as a cause of their pneumonia?
Do you know I don't actually?
I ask because this is just a nice way of looking very clever on a ward round. Whenever
Go on
someone
then.
has pneumonia and their CRP is north of 300, it's
Yeah.
nearly always strep pneumonia.
Mm.
And I just a little trivia thing I have, and that hasn't steered me wrong so far. And you look very clever when you identify the bug based on the CRP. Did you know that CRP was first described in context of pneumococcus infection? That's why it's called
Yes.
C. The C stands for C polysaccharide on the coating of pneumococcus. And so when you get a CAP, a community acquired pneumonia, with a really stonking CRP 300, 400, you can say, aha, this will be strep pneumonia, and send that urinary antigen, and then it comes back and it looks fantastic. So that's my
And you
only.
look very clever.
You look great, and the patient gets the right antibiotics. That's even more important. So that's my little nugget from that case that occurred to me when you told me that 300 of CRP or whatever it was.
Yeah. So actually, that's a good point. I probably should go back and check actually, just to confirm your brilliance and your great
If it
idea.
isn't, keep it to yourself. Let's keep it at 100% success.
Fantastic. Okay. Thank you so much for joining me again today, Ben. I hope everybody has taken away some learning points from that case. I think we've had a really good discussion about cognitive biases again and about premature closure, visceral biases, and certainly touched on, the importance of proper, thorough examination. So I hope everybody enjoyed listening to today's episode, and we will be back soon. Thanks for listening.
Thank
Goodbye.
you. Bye-bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.